Hello and welcome back to Science of Medicine. In the next few videos, I want to talk in more detail about medical physiology of the lungs and the pulmonary system. I'm going to break this into a couple parts and then try to show you some clinical applications of this. The first part I want to deal with is the anatomy and the ventilation, the movement of air in and out of your lungs. So let's get started. Your pulmonary system is designed to allow for gas exchange. This occurs at very small structures called the alveoli. They're buried deep within the lung. And that gas exchange is to bring oxygen in. This is needed, if you remember, for aerobic respiration via the Krebs cycle. And that oxygen is being exchanged and transported to the rest of your body by hemoglobin in the blood. And then carbon dioxide, a waste product from that aerobic metabolism, is going to be transported and exchanged out in the lungs and then expired. This is mostly transported in the blood as bicarbonate, and it is the main determinant of the pH in blood. And we'll talk a bit about that also. In order to have an exchange of gases, you have to constantly renew your lung gases. In particular, you have to renew the oxygen and get rid of the carbon dioxide. And this is the purpose of ventilation. Ventilation is going to cause the movement of air into and out of your lungs so that the alveoli can have gas exchange. Now, this is under the control of your central nervous system. There is a respiratory center in the brainstem, the medulla oblongata, and the pons that actually control this, so you don't have to think about breathing. And there are sensors that allow for the monitoring of these two gases, carbon dioxide and oxygen. And it's a bit more complicated than what I'm going to allude to, but we will say that the set points for carbon dioxide are going to be about 40 millimeters of mercury, and for oxygen, about 60 millimeters of mercury. In fact, the sensors actually don't change much between 60 and 100 millimeters of mercury for oxygen. And the sensors for carbon dioxide are actually acid sensors. So let's look at the anatomy. So the gas exchange is occurring at alveoli, these very small structures within the lungs that facilitate gas exchange, and they're highly vascularized. Those alveoli are terminal branches of a series of bronchial tubes that actually bifurcate constantly as they go from the intake of the pulmonary system, which is through the trachea. So you basically are breathing air in through your nostrils. It'll go up this way, or you can breathe it in through your mouth. There's a common connection in the back. It will go down the front pipe, so to say, your trachea, which will then go down and bifurcate into the right side and the left side of your lungs. And then these large bronchi will then continue to split and split and split, and eventually will terminate in groups of alveoli. Now, your lungs are housed in your thoracic cavity, and the thoracic cavity is under a slightly negative pressure. There is a negative pressure between the outside of the lung and the inside of the thoracic cavity. There's a small amount of fluid called pleural fluid to help lubricate this. And this allows for expansion, as we'll talk about in a little bit. There is a large muscle that lies underneath the lungs that will facilitate most of the ventilation. This muscle is called the diaphragm. It is a skeletal muscle. It is under the autonomic or automatic nervous system, but you can also control it. Now, as I mentioned to you, the primary mechanism by which ventilation occurs is movement of the diaphragm. As I inhale, the diaphragm will flatten and the interthoracic pressure will increase, and this will move air into your lungs. When I exhale, the opposite occurs. My diaphragm will relax, my interthoracic pressure will drop, and air will flow out. I do have some additional muscles, particularly the sternocleidomastoid muscles up at the top, and small muscles in the ribs in between that are called the intercostal muscles. Under most circumstances, I don't need to use those for ventilation, but sometimes you will see people that are in respiratory distress that do need to use them, or sometimes I use them if I need to ventilate large volumes, such as after I've exercised. So let's explore this a little bit more in detail. So the movement of the diaphragm is going to change the pleural pressure from about -5 centimeters of water to about -7.5 centimeters of water. I apologize for these archaic units. Normally we would talk about pressures in being millimeters of mercury. However, historically for lungs, those are measured in centimeters of water instead of millimeters of mercury. So you have an increase in this negative pressure. And what that means is, if I look here at this diagram where this darker green balloon, if you will, is your lungs, and this lighter green area here that it's housed within is at -5 centimeters of water. If I were to just lower the pressure, that balloon that's inside will actually expand. And that's the similar thing to what's happening actually in your lungs. You will actually contract your diaphragm, and in doing so, that will increase the negative interthoracic pressure, and air will flow into your system. When you relax the diaphragm, the opposite will occur and air will flow out. Now, there are several ways that we can think about how much air we are ventilating. Ultimately, what matters is the gas exchange in the alveoli, so what matters is how much you're ventilating the alveoli. And as you can imagine, from getting from my mouth or my nose down into those alveoli, there's some space or some volume that needs to actually be exchanged. And so I have a certain what's called dead space or dead volume that isn't going to get exchanged because I have to breathe in a certain volume. I can't skip over my trachea or something like that. So normally, when I am breathing normally, such as what you may be doing right now, the amount of air that is moving into and out of your lungs is what is referred to as the tidal volume. And this is typically for an adult about 500 milliliters. So it's a fairly small amount. However, you have the ability to increase the amount of air that you actually breathe in. This additional amount is called the inspiratory reserve volume. So if you watch, if I'm breathing as my tidal volume, I can access that inspiratory reserve volume by breathing in more than what my tidal volume would be. And likewise, I have an expiratory reserve volume. I can actually expel additional air out of my lungs beyond that tidal volume. So I'll demonstrate here. I'm breathing normally, and then I will access that expiratory reserve volume by, and that additional air out is my expiratory reserve volume. Now, the sum of all three of these, the inspiratory reserve volume, the expiratory reserve volume, and my tidal volume, is what I call my vital capacity. Now, this is not my total lung capacity because I can't suck every bit of air out of my lungs. There's a small residual volume. And this residual volume is important because in some diseases, it turns out that you actually can increase this residual volume, and the effect of that is that your vital capacity goes down. I can measure these lung volumes through a technique called spirometry. Spirometry is done in an office-based setting and involves you breathing in and out through a certain sensor that can measure things such as flow and time and therefore get volume. It is effort dependent. You can control whether you have a big inspiratory reserve volume or a small inspiratory reserve volume that you actually access. But if you try, then you would actually be able to get reasonable spirometry flow loop curves. So what happens is that when you are doing spirometry and you're breathing in and breathing out, you're measuring this flow as a function of time, which you can then convert to volume. And so we have two loops. This bottom loop in red is during inspiration. And inspiration in spirometry is normal. I'm just inspiring like I normally would. But the expiration is a little different. Expiration wants to access that inspiratory and expiratory reserve volumes. So what I'm going to do when I breathe in is breathe out as rapidly as I possibly can. And that leads it to not being symmetrical with this inspiration, because I'm actually trying very hard to breathe out very rapidly. So the peak expiratory flow, the maximum expiratory flow rate, is bigger than my inspiratory, and that's why this is higher. And then of course the area under here has got to be the same, so therefore I'm actually dropping this at a steeper amount. I have many different ways that I can characterize these flow loop curves. I can look at the total volume, the forced vital capacity that we mentioned before. I can characterize the amount of forced expiratory volume in 1 second relative to this. I can do it in the 25th percentile, 50th percentile, 75th percentile. I can do other things like that. I can characterize by the shape of the flow loop curve, tell me something about the diseases, and I can even get the peak expiratory flow rate, and we'll talk about some of these. I'm going to remind you that airflow is modeled as laminar, and so Poiseuille's law is used. Very, very important thing to understand. The biggest thing that I want you to remember is that flow is proportional to the 4th power of the radius. Let me say that again. Flow is proportional to the 4th power of the radius. So of all the things that you can influence, the radius is the most sensitive changer of the flow rate. Increase the radius a little bit, flow rate goes up a lot. Now the pressure drop you could maybe do a little bit with. Viscosity, you're breathing the same air. The length of the tube is based on how big you are. So all these are pretty much relatively constant, but that radius is not. And you can constrict or dilate your bronchial tubes. Now, of course, this is not one single tube, like I perhaps alluded to with this formula, but a series of tubes. And so this is an important thing that you need to remember. We'll talk about it in a little bit. So let's look at some of these flow loop curves and link that to diseases. So there are different ways to characterize lung diseases. One of the ways that you can characterize and classify some lung diseases is with spirometry. It is not the definitive way for doing that, but it's useful for talking about it here. One type of lung disease in this classification are obstructions within the airway. Now, the obstruction could be something that is fixed, a tumor, stenosis, or a narrowing of a particular tube. That's one. Or variable obstruction. These are diseases such as asthma or emphysema, which can narrow through inflammatory mechanisms the bronchial tubes, and that can result in decreased flow. Now, if you look at the flow loop curve, where I'm plotting flow versus volume, if I look at the green curve, it's normal. So this inspiration on the bottom and forced expiration on the top. If you have an obstructive disorder, such as COPD or emphysema, you will see that the peak expiratory flow rate is decreased relative to the normal, and also it drops a lot faster than what it would normally do. And in fact, we can quantify this as a ratio of the forced expiratory volume at 1 second versus the forced vital capacity, which is not changed, and that's generally less than 0.7 when a person is having this kind of an obstructive disorder. And as I mentioned to you, this also affects the peak expiratory flow rate. And so these are two quantitative measures that I can get from a flow loop diagram for a person with an obstructive disorder. If I have a fixed airway, such as tracheal stenosis or a tumor, then what happens is that as I breathe in or as I breathe out, the flow is limited, and it just simply stops at a certain level and then goes back down. And that's indicative of a fixed obstruction. In contrast, lung diseases that are restrictive affect the lung tissue or the lung cavity so that the expansiveness of the lungs is decreased. So things like pulmonary fibrosis or severe scoliosis affect this. And in this case, the normal flow loop curve here in green is different from the restriction. It looks similar, it's just got a lower forced vital capacity and peak expiratory flow rate, but the ratio of the FEV1 to FVC is generally unchanged because they're affected proportionately. This is similar to neuromuscular disorders such as Guillain-Barré syndrome or amyotrophic lateral sclerosis or Lou Gehrig's disease, where you have weakness of the diaphragm, and that means that you can't expand your lung. In this case, just like in other restrictive disorders, the forced vital capacity and peak expiratory flow rates are lessened, but the FEV1 to FVC is nearly changed, appreciably unchanged. The difference here is more one of shape. It's very, very difficult when you have neuromuscular weakness to force anything out, and so it tends to look more symmetrical. I want to talk about two other concepts here that are very important for lungs and lung ventilation. The first is compliance. Now, compliance of any material is just simply the change in volume with respect to pressure. What that means in terms of lungs is how much can I expand versus how much pressure do I need to actually have to do so. So if I look at this volume pressure diagram and I have this curve, you can see that I have highly compliant material down here and then lower as it sort of bends over. And this lung compliance is influenced by a couple factors. First off, there is elastic tissue within the lungs that allow for recoil and expansion. And then there's also surface tension, which we'll talk about in a second, related to the fluid that is inside the alveoli. So lungs that are not very compliant, what that means is that it requires a higher pressure to ventilate. And that's an important consideration because there are disease processes that decrease the compliance of the lungs. Now, when I open up my alveoli to permit for gas exchange, the law of Laplace is very important to understand. The law of Laplace relates the pressure inside a sphere to the surface tension and the radius. And this is really, really important. It has very important ramifications for lung dynamics. The first is that since the pressure and the radius are inversely related, smaller radii spheres will have larger pressures. Let me say that again. A smaller sphere will have a greater pressure inside than a larger one. What that means is that if you have alveoli of different sizes, air will spontaneously flow from small alveoli to large alveoli. This is a real problem in certain diseases such as emphysema, where the alveolar structure breaks down and you wind up with what are called bulla, which are basically these large collections of alveoli. And what happens is it's very difficult to ventilate the smaller alveoli because the air spontaneously will flow into the large bulla. Now, if I look at the pressure related to the surface tension, if an alveolus is about 100 microns and has just water inside, that gives a surface tension of about 0.07 newtons per meter. So you need about 18 centimeters of water pressure to open the alveolus. Well, you can't do that. You've got at most 7.5, so you can't open alveoli that collapse. So we have this chemical inside our lungs, a surfactant that decreases the surface tension so that you only need about 3 to 4 centimeters of water to open up the alveoli. Without this surface tension decrease, you could not survive. And it is one of the things that used to limit the viability of infants when they came out of mom too early. And so these pulmonary surfactants are critical in this. Now, as I mentioned, the control of ventilation is under the central nervous system control in the brainstem, the medulla oblongata, and the pons. There are two sensors. One is chemosensors for CO2. Technically, they're for hydrogen ion, but CO2 is linked to the hydrogen ion, as we'll talk about in another video. High carbon dioxide, generally greater than about 40 millimeters of mercury, will stimulate the main nerve that controls the diaphragm, the phrenic nerve, to increase the respiratory rate, blow off or ventilate carbon dioxide. Chemosensors in the carotid arteries, which go up to the brain, the aorta, which comes off of the heart, contain oxygenated blood, and if the partial pressure of oxygen is less than 60 millimeters of mercury, it will stimulate the phrenic nerve to increase the respiratory rate. As I mentioned to you, the phrenic nerve is the main nerve that's controlling the diaphragm contraction, and this comes off at the cervical level of about C3 C4 to C5, which is why if you break your neck, you can actually die of asphyxiation because you can't breathe because the phrenic nerve is not allowing that. Now, sometimes people require additional assistance with breathing. This is called mechanical ventilation. What's happened is a tube is placed in the trachea, a little cuff is inflated here to seal it, and then this is hooked up to a mechanical ventilator, which is something you see over here. The physician will then be able to control different parameters that relate to ventilation. The way I like to break these into pieces is there are a few controls that will control or affect the oxygenation, the fraction of inspired oxygen, which can go from the 21% of air up to 100% of pure oxygen, and the pressure, the positive and expiratory pressure, which is a way of saying how much am I going to distend my alveoli. Both of these influence my oxygenation. The ventilation from the tidal volume, which we talked about, and then the minute ventilation, how many times you're breathing per minute, is controlling the carbon dioxide and the pH of your blood. I hope this has been helpful for you in learning about the lungs and ventilation. We'll come back and talk about respiration soon. As always, I'm happy to have you subscribe to this channel, or you can like or leave me comments. I'll see you soon.